All right, thanks everyone. My name is Ram. I'm from Columbia. I'm an interventional radiologist. It's good to be here. Thanks for your time. I have no financial relationships. So I'm going to be presenting, as I said, about the Penumbra Indigo system. It's a mechanical suction thrombectomy platform that's designed for clot extraction in the arteries and veins, including PE. They have a portfolio of catheters of sizes and shapes that were purpose-built for this, which range from 3 French to 16 French, depending on the vessel size. Penumbra is a neurointerventional company at heart. It initially started treating strokes and expanded in 2013 with the Pump Max system and the CAT3 into the peripheral space. Flash forward to today, they have the Lightning Flash catheter, which is 16 French, and it's the most advanced system for larger bore vessels. And so the heart and soul of this device is the Penumbra aspiration engine. It's a simple on-off platform. When you turn it on, it creates a consistent 29 millimeters of mercury vacuum through which the catheters perform their suction. It also has a clot catcher within the canister, which provides live feedback during the case. So the initial criticism of the device was that it, especially in the larger bore devices, was a bloodletting product. It would just turn on and it would just, the operator would have to think about how much EBL there would be during the case. So Penumbra developed the Lightning add-on. It's this device that's here, and it sits between the catheter and the canister. And it contains a microprocessor with a proprietary thrombus removal algorithm that detects real-time blood flow as well as clot. And it controls a automatic valve that rapidly switches between on and off. It's also connected to a light, as well as provides the operator with real-time feedback during the case, so that they're not thinking about whether or not the machine is sucking blood. They're just thinking about the case. So I'm just going to go through the way that this device sort of works when you're operating it. And so I think there should be audio on this slide, but if there's not, it's a device that when it's green, you just hear clicking about 1 second at a time. And at that time, I'll play it again, it's sampling about 0.3 cc's of blood per second. There you go. And then when it detects clot, you can hear it in a more rapid manner, and it turns orange. And when the flash mode is activated, so this comes with the flash catheter. The Lightning Flash device is black, and the other catheters are white. This mode is rapidly switching on and off, and it's meant to suck out as much clot as possible. And then you have it turn yellow, and there's no aspiration being performed because it detects that there's a occlusion at the tip. So the Lightning Flash catheter, it's a 16 French catheter. It comes in ranges from 80 to 115 centimeters. And it's made of stainless steel that has multiple, it's called a multi-pitch laser cut platform hypotube that is extremely torqueable 1-to-1, and it can be delivered and manipulated without the use of a wire, which is something that I think as a interventional radiologist who was taught never to lose wire access, it's something to really come to terms with. It comes with 2 shapes, the X torque and the H torque, and by turning it 360 degrees, the shapes allow it to really grasp the wall of the vessel and take out really wall-adherent clot. And so just wanted to talk about some of the research that's been done developing these catheters. The first was the Extract PE trial that was published in JACC by Dr. Sista. And it was a single-arm prospective study looking at the Indigo Cat8 platform. The primary endpoint was change in RV-LV ratio, which has been the historic surrogate marker for these trials, compared to baseline to 48 hours post-procedure with a CTPE. And so they found a 27% change in RV-LV ratio at 48 hours with minimal major adverse events, and patients were able to be discharged relatively quickly on a DOAC. And this really validated the role of mechanical aspiration thrombectomy independently of NRE's FLARE trial. So this is sort of where we started to pick up more steam for aspirational thrombectomy alone versus infusing TPA. So this led to the design of the STRIKE-PE trial, which is currently ongoing. It's a prospective post-market study designed around the Lightning platform and the CAT12 catheter. It's a planned enrollment of about 600 subjects across 55 sites. And it looks at not only 48-hour follow-up, but also in the medium and in the long term at up to 1 year. The PI is Dr. Moriarty out of UCLA. And it started in 2021. It's going to finish around 2024. And the primary performance endpoint for this was, again, looking at RV-LV ratio from baseline to 48 hours, looking at the secondary endpoints, including quality of life and functional outcome at 90 days, incidence of device-related serious adverse events, and any cause mortality within 30 days, as well as symptomatic PE recurrence. They're also looking at major adverse events as safety endpoints, including major bleeding, device-related death, clinical deterioration, pulmonary vascular injury, and cardiac injury. So the interim analysis of this trial, based on the first 60 patients, was presented at Viva, and the abstract was presented recently in JVS. So 57 had submassive PE, 3 had massive PE, and the procedure was performed using the CAT12 2.4 days from symptom onset, within a day of admission, and 34% were actually able to avoid an ICU stay altogether. So it was, again, shown to be safe, a major adverse event about 1.7%, and no mortality at 30 days. The RV-LV ratio at 48 hours was shown to decrease by 24%, and the systolic pulmonary arterial pressure was shown to be decreased at about 20%. Functionally, the patients felt better on discharge, had less dyspnea, and at 90 days were able to walk farther with a 6-minute walk test. So the next natural iteration of this question is, well, how well does this catheter plus anticoagulation compare to anticoagulation alone, which, you know, historically has been the gold standard? So that led to the STORM-PE trial, which was created. And basically, this is a prospective randomized parallel assignment trial that's going to be the first to provide randomized data comparing mechanical aspiration thrombectomy with anticoagulation to anticoagulation alone. So it's designed around the Flash catheter, the 16 French platform, and it's going to enroll 100 subjects with intermediate high-risk PE across about 20 sites. The PIs are Dr. Rosovsky out of MDH and Dr. Lookstein at Sinai. So the trial has just started enrolling patients in August of 2023, and it's going to finish around 2026. So the primary endpoints are, again, change in RV-LV ratio at 48 hours, major adverse events at 7 days are the secondary endpoints, including composite clinical deterioration requiring escalation of care, PE-related mortality, symptomatic recurrent PE, and major bleeding. But also, it's going to look at functional outcomes as well as quality of life through 90 days. So it's including these quality of life questionnaires as well as functional tests, including the 6-minute walk test and various scales that are listed here. Also, obviously, looking at all-cause mortality, PE mortality, and symptomatic PE recurrence at 90 days. So the inclusion criteria for this include clinical signs and symptoms with acute PE of duration of about 14 days And as Dr. Morris had mentioned, the intermediate high-risk PE patients evidenced by RV-LV ratio greater than 1.0 with elevated biomarkers. The exclusion criteria are listed here. So this is just a case highlighting how effective the lightning flash can be. This patient presented intermediate high-risk PE. I'm going to let it play again, but there's large clot burden greater on the right. There's main PA with lobar extension and lobar PE on the left. So the catheter was advanced into the main pulmonary artery on the left. It was used to select the lobar segments and then switched over to the right to select the right lobar arteries. And you can see here the organized clot that was retrieved during this procedure. And you know, I think these pictures highlight how torqueable and flexible this catheter is. And this was done, the majority of it, without the use of a wire. Pre-intervention, the main PA pressures were 61/14 with a mean of 34. Post-intervention, the main PA was 45/7 with a mean of 22. The patient immediately reported feeling better with less chest pain on the table, spent a single day in the ICU and was discharged in day 4. There was about 30% reduction in RV-LV ratio, initially 1.42, and at 48 hours, 1.1. So thanks again for your time. I think this is a pretty neat space. With the STORM PE trial, we have HiPythos with ECOS. We have PE Tract, which looks at all of the various devices. So it's a great time to sort of see what goes on in the next couple of years. So thanks for your time.